can we please welcome Rafa, who is now with us. We've gone back to Rafa's first case. Rafa?
I'd like to present a case.
Essentially a 43-year-old man who was diagnosed with low-risk chronic phase CML in August of 2021, started imatinib. He developed thrombocytopenia, so his dose was reduced about a month after starting. Platelets came up with lower dose imatinib, and he did okay for about 6 to 7 months, and then platelets dropped again into the 80s. Imatinib was held. He had a bone marrow biopsy that showed lymphoid blast phase CML. So he was then treated with hyper-CVAD plus dasatinib and achieved at least a morphologic remission. I don't know that we have the molecular response data, and he underwent a haploidentical stem cell transplant. So I guess the topics really to discuss are the goals of induction chemotherapy for lymphoid blast phase CML, and then the BCR ABL levels and the dissociation of BCR ABL levels in blastic transformation, because I think his BCR ABL levels were not terribly high, 1.2% shortly before he transformed, and then the role of transplant in these patients. Is that kind of an accurate summary?
Yeah, looks like.
Okay.
I think it certainly is surprising that he's had a good initial response, and then took blasted off within 6 months. Despite that, obviously showing, I think he maybe right from beginning had an alternative pathway that was active, and quite often there may be a cytogenetics that we may miss, or they're cryptic and we may not find them. So maybe something like that is, as of yet, we don't know. Maybe the mechanism why in 6 months with a good response taken off. There was a publication from Emory University here where they looked at flow at the time of diagnosis. Normally flow is negative or myeloid positive in CML, but if the flow has lymphoid markers at the time of diagnosis, even if it's in chronic phase, there was a high chance of progression to lymphoid blast phase within a year, even in low risk CML. So I think something like that, I mean, that was a retrospective study, again, has its own limitations, but things like that may point us maybe why people like him take off and have blast transformation in 6 months or 8 months post a low risk CML. I think I still, one of those that use hyper-CVAD with TKI for pH positive ALL and CML with ALL transformation, lymphoid transformation, because it's an easy regimen, easy to give, and should be able to get into remission either with dasatinib or even ponatinib with hyper-CVAD. And then certainly look at considering a bone marrow transplant for a lymphoid blast phase. I know some of the newer regimens coming out where they're using TKI plus blinatumomab. It certainly is an expensive regimen and may not be always appropriate for the entire population, even in US. I know people from lower rural areas may not be able to get that regimen as compared to a city-based. But I think the hyper-CVAD and TKI certainly is a way to go with the chance to go for transplant at the earliest possible.
Yeah, I definitely would agree. The use of induction regimens in blast phase CML, I think there's kind of mixed. I think there could be some. I know there's some data that's come out of MD Anderson suggesting that outcomes look better with induction plus TKI versus just TKI alone. We've looked at our own data here and actually found there was not really any difference in outcomes with the addition of induction. And but you know, I think there's also a difference in the lymphoid blastase versus myeloid. The myeloid patients, at least, and again, this is another gross generalization, but seem to have a lot more fibrosis and tend to have a harder time recovering from induction. But the lymphoid patients with hyper CVAD and a TKI seem to do okay. But whatever approach you take, be it induction plus a TKI or just, you know, ponatinib as a single agent, however you choose to go about it, I think that the end goal should, in these cases, pretty much always be transplant, whenever possible, in my opinion.
No, I certainly look for transplant option as well. And I agree. I think TKI with steroids is possible. I think Europeans have done it a lot, where they looked at TKI plus steroids induction followed by low dose and chemo and then transplant, but that is with the availability of donor and so on. So I think that's certainly an option, TKI alone, or certainly TKI alone in myeloid blast phase and TKI with steroids in lymphoid blast phase. But I think chemo plus TKI is a reasonable option too in lymphoid blast phase, and ideally it would be best to have a donor available if possible.
Thank you, Rafa. The very difficult audio situation that that you have with whatever the volcanic activity is doing to your reception.